afternoon, everyone. So, as ma'am told, I am Abhishek. I am currently deployed as a nursing officer in the Department of Hospital Administration. And the topic that I'll be delivering today is about the quality indicators in the ICU. Now, as Dr. Shaleen has already paved the way for what quality indicators are and why quality is important, as told by Dr. R. Harshvardhan. So, I'll basically will be exaggerating on those points only. So, this basically will be relating to what all auditing is. As so very rightly said that most of the service class employees are very afraid of what auditing is. But to put it in a better sentence or in other good words, it was told that it can be called as a service evaluation or practice evaluation. So this will be pertaining to all those areas. So we'll be discussing about the quality indicators and why are they important. So we'll be referring to the NABH 6th edition, that is the National Accreditation Board for Hospitals and Healthcare Providers. So we'll be referring to the 6th edition that was rolled out in January 2025. So now any hospital that wants to undergo NABH assessment or they want to get NABH accredited, they'll have to go through the 6th edition. So 6th edition basically is a little advanced. Every year the NABH committee, what they do is they take out the key performance indicators and other standards and objective elements from their set of guidelines, and they revise it further to join the Joint Commission International Standards and the WHO standards as given by WHO. So what the ICU quality measurement frameworks will be, basically, as you all know that ICU is a high risk setting and it requires continuous evaluation. So what we'll do is the quality indicators that we'll be discussing basically will help the medical professionals, the allied health professionals, the nursing professionals to basically see as to whether the patients are getting effectively monitored or not. So that will be the outline of the KPIs, of discussing the KPIs. The NABH 6th edition mandates the use of key performance indicators. Now, there are certain key performance indicators that in the earlier editions were not mandatory as per the NABH, and the hospitals had the liberty to whether go for the KPIs, they want to capture those KPIs and evaluate them or not. But now in the 6th edition, what they have done is they have mandated the 32 key performance indicators. We'll be discussing only the ones that will be applicable in the ICUs and not the ones that are applicable to other parts of the hospital, because NABH basically to different services that the hospital provides. For example, the laboratory services, the radiology services, all these services are also covered under the NABH. So we'll be discussing primarily the key performance indicators that are pertaining to the ICU settings. So what the KPIs do is that they measure the patient outcomes. They help you to measure whether the patient outcomes, whether the patient will have a mortality or whether or not we can prevent it. So all these can also be measured using the KPIs. It also improves the process efficiency. Now, how we do that? When we look at subjectively, when we look at the KPIs, we'll see as to whether these KPIs or how these KPIs improve the processes. And yes, obviously, because patient safety is the umbrella under which NABH, which is the national accreditation body for India, and the Joint Commission International, which is the international accreditation agency for any hospital in India or abroad. So all these basically come under the umbrella of patient safety. So KPIs also will align with the patient safety standards. Now KPIs are also helpful in identifying the trends. They reduce the incidence of adverse events and they strengthen the data-driven decision making. Now, how it affects the decision making for the administration as well as for the nurses working on the floor. So we'll look at that. Now, why KPIs matter? Now, a lot of times the question arises as to why do we need to capture the KPIs, or what is the use of capturing this KPIs is. So basically, as you can see, this promotes safe and evidence-based care delivery. Now that is very important because now we are moving towards the evidence-based practices. Now, how do we create this evidence? This evidence is created only with the help of a data and the analysis of this data. Now, this data helps you to make a proper decision as to why it is important. For example, like sir told that there may be incidences of extravasation while IV cannulation in any hospital setting. Now, to know as to how many extravasation incidences are happening in a particular setting, for example, the ICU, we'll have to have a look at how many extravasations are happening in a specific time period. For example, you can consider the time period to be a month. So for example, in a month, there will be 10 incidences of extravasation that are happening because of IV cannulation. Now, our journey through this KPI, or through capturing this KPI, or through capturing this data, will be to reduce the number of incidences of extravasation. So that is how it goes. So this is basically a journey, and there is no destination to quality or patient safety. We cannot ever reach to 100% patient safety level, or 100% quality institute, or a quality nursing care, or a medical care, because that is a journey in itself. Every year there will be new standards that are being rolled out. Every year there will be new set of guidelines that are being issued from different bodies. So all this is happening, and anyone or anybody, if they think that they have come to a position where they don't need to learn anything new, is practically not possible. So that is completely hypothetical. Now, ICU KPIs will also ensure accountability and transparency across departments. They also support data-driven quality improvements, and they also demonstrate measurable results during NABH assessment. So if at all our hospital, or any hospital for that matter, because a lot of participants have also joined from other institutes, so they will be either going for NABH assessments, or maybe working at institutes that are NABH accredited. So they would know that how this NABH assessment goes. Now, the global context of ICU indicators. Now, we'll be discussing primarily about the indicators from the NABH 6th edition, but there are other editions also. For example, the Joint Commissioner International, as I told, is an accrediting body for international hospitals. So those standards are also there. Then WHO has also given certain set of standards, but we'll be primarily looking at the NABH 6th edition standards, because this basically applies to our settings. Any hospital in India, if they want to get accredited, so NABH is the first pedestal that we go for. It expands the focus beyond infection control to holistic quality management. Now, this is important because earlier, when the KPIs were in the very nascent stages of its development, so KPIs were basically focused on the infection control practices. For example, incidences of hospital-acquired infections, for that matter. For example, how many cases of catheter-associated urinary tract infections are occurring in a hospital or in a particular setting, CLABSI, ventilator-associated pneumonias. So this was the primary objective of the KPIs. But now, as the 6th edition is being rolled out, and as the quality and patient safety are being thought of differently, and the medical knowledge is changing rapidly than ever before. So now the focus of these KPIs is more towards the holistic improvement of the patient outcomes. They are also now involving the patient family satisfaction levels. So all this is happening. Primarily, the infection control practices were the first thing that the KPIs captured, but now it is more towards the quality management. It also integrates digital dashboards, predictive analysis, and real-time monitoring. We'll discuss about what these predictive dashboards and digital dashboards are. Then it encourages proactive rather than reactive quality management. Now, this is an important point here, that earlier, or even for today, some of us basically are reactive in approach. For example, a problem occurs and then we try to fix it. But now, as the standards are changing, we'll have to move towards a proactive approach, wherein we reduce the incidences of these problems. We reduce the incidences of extravasations, for example, because that is the first example that we all learned today. So to reduce the number of incidences is our primary objective, and not to capture them and then see as to what we can do. So this is what basically means to go into a proactive approach rather than a reactive approach. Now, this is basically a chart that tells you about how the 5th edition has changed to 6th. In this, the 5th edition, it was more about infection control and mortality. It was focused more on that. But now in the 6th edition, it is more focused on the comprehensive quality and safety. The 5th edition was more towards manual auditing, but now with the 6th edition, it is more towards the HIS, or electronic medical records based tracking. So now if at all any hospital wants to go for NABH assessments, with the 6th edition, they'll have to have a HIS based system in their hospitals. Now, we are lucky enough to be sitting in an institute which basically was spearheading the HIS since the early 2000s. So we have been using the HIS. Now, as going forward, if we at all our management decides to go for NABH accreditation or any sort of patient safety or quality standards, we'll also have to basically integrate all these KPIs into the HIS systems. In the fifth edition, the patient role was very limited, but now, as I told, in the sixth edition, they have also involved the family engagements, and they want to see whether the patients themselves and their family members are satisfied enough with the quality of care that they are receiving. Fifth edition was more focused of capturing the KPIs and then holding a quarterly review. So every 3 months we used to capture those KPIs, and every 3 months we used to revise them or have a review meeting with the stakeholders every 3 months or quarterly. But now what they've told is it is to be done monthly. So any KPI that you're capturing will have to be captured on a monthly basis and then reviewed subsequently. And then preventive and corrective actions based on what the data has been given will have to be taken every month. And also in the fifth edition, the reporting was more focused on manuals. For example, people who have worked in the private sector or the corporate hospitals would know that there were Coti care bundles, there were VAP care bundles or Clapsy care bundles that were deployed in the clinical areas. But now it is more towards building digital dashboards and the analytics. So this is the NABH framework. Now the KPIs that we'll be discussing will be divided into 4 different areas. The first area will be the clinical outcomes. The clinical outcomes will have the KPIs related to mortality of ICU readmissions and the sepsis bundle compliance. Now sepsis bundle compliance is the latest addition of the key performance indicator in the 6th edition. Earlier there was no such indicator as a sepsis care bundle, but the NABH Quality Council basically thought of including this because a lot of times the patients, we were losing out on patients that were getting admitted to either ICUs or in the emergency areas with sepsis and septic shocks. So the clinical outcomes will be the part of the KPIs that will be more the probability of losing the patient or not providing the patient with a better medical services will be covered under the clinical outcomes. The next will be the infection control. Now this basically all of us mostly know about ventilator associated pneumonias, the incidences, the Clapsy, Coti and pressure ulcer incidences. So this basically most of us know. Then there will be process efficiency, as the KPIs that will be covered under will be the staffing ratios and the effective communication. Now effective communication and the handover of nurses. Now nurses in any hospital will have a handover register, and the nurses will mostly follow the handover techniques, the proper handover techniques. Now the NABH 6th edition has given a few guidelines as to how a proper handover should be, but nurses mostly do it because ever since we were students and then we got into private hospitals and then subsequently into the government hospitals, we have always been, and even today all the nurses are doing proper handover during their shift change. But the problem basically is with the doctors because there is no proper documentation of the handover of patients with doctors. So when we faced assessment in different institutes, we saw that the NABH assessors will mostly point out on the handover communication between the doctors because they know the doctors will never follow the handover communication. So this will be improving the process efficiency, and the last will be the patient safety and experience. Now, as 6th edition already told, that family satisfaction and the patient satisfaction have become a cornerstone for the 6th edition. So we'll be including the patient's family members also if they are satisfied with the kind of services that they are receiving in the hospital. So that will be one part of the patient safety and experience, and then maintenance of hand hygiene and reducing the incidence of medication errors. So we'll be moving on with the performance indicators. The first we'll be discussing about the clinical outcome indicators. Now, first is the standardized mortality ratio. Now, the standardized mortality ratio by definition measures the number of actual deaths as compared to predicted deaths in the ICU. Now, many hospitals don't do that, but it is mandatory for the ICU settings to have a kind of scoring. The Apache score, as you see in the remarks, is basically acute predicting acute physiologic and chronic health evaluation score. So this is Apache 2 score that the ICU uses. Now, I'm not sure how many of the ICUs are using it, but the Apache score basically gives you an idea when the patient is getting admitted to the ICU, or the first and foremost thing that is to be done is by the doctors to give that patient an Apache score. So this basically is a scoring sheet which ranges from a -4 to +4 through 0. So basically, if a patient is having his vital signs or mean arterial pressures or even GCS, all these status are measured using the Apache score, and it gives a prediction of whether the patient is going to survive or not. The higher the score, the lesser is the chances of the patient survival. So this score can also be used in the hospital. Then there is a SOFA score, that is the sequential organ failure assessment. Then we have the SAP score and the MPM score that are used in different ICU settings. Now, what is to be done is, how do we capture this KPIs is, earlier as per the 5th edition, we could have a separate form for any patient that is getting admitted to the ICU. For example, a patient comes to the ICU, we receive the patient. While we are preparing the file, we'll attach this Apache scoring on the patient's file, and whenever the doctors pay their first visit to the patient, we'll use this Apache score for measuring whether what will be the patient's outcome. And then at the end of the patient's tenure in the ICU, whether the patient, there will be 3 probable outcomes. Now, either the patient can die, the patient can be shifted to wards, or the patient will be continued to stay in the ICU. So at the end of his tenure in the ICU, at the end of his tenure, we'll be looking at what the Apache score predicted at the admission of the patient. So this is how we come to know that whether the Apache score has properly predicted the mortality or not. For example, suppose, for example, if a patient has come to your ICU setting, and in that case, you've predicted, or the doctors have predicted, that the patient will have a high mortality rate, or there are lesser chances of the patient's survival. But at the end of his tenure, he gets discharged from the ICU, or he becomes better and gets discharged to a step down unit or to the wards, and then subsequently he could go home. In that case, it basically tells you about how good the ICU nursing care was, how good the medical care that was given, or how good the patients were handled clinically in the ICU. So this basically tells you, so Apache score or the SOFA score are different scores that are standardized scales that can be used in the ICUs to capture the standardized mortality ratio. So what is the formula for doing this is basically how many in a month, how many actual deaths happened and how many were predicted. So this basically will give you a ratio that is to be calculated monthly, and this can be done, earlier it was being done using a form that was put on the patient's file at the time of ICU admission, but now it has to be integrated into the HIS or the EMR, the medical records. Next, we have the return to ICU within 48 hours. So this also is an important indicator. It is easy to capture, but many hospitals basically omit this, that if the patient is getting readmitted into the ICU after getting discharged from the ICU. So discharge here is not meant that the patient is going home. For example, when we refer to discharges, we basically see that the patient is now going home, but getting discharged from the ICU is basically saying that patient is now going to either step down units or into the wards. So when the patient is getting discharged from this ICU, whether or not this patient is returning to the ICU within 48 hours. Now, a lot of times when the patients, as of my personal experience, now a lot of experienced ma'am and sirs are sitting here, they would know. But out of my example that I have seen, many patients who are getting discharged from the ICU with type 2 respiratory failures, they will now will be put on BiPAPs in the ward areas. Now, the problem in the ward areas is that there are family members, the patients, whatever tantrums the patient has to play, the patients will play it and they won't put on the BiPAP, because obviously that is not a good experience for the patient. So they'll try to restrict the putting on of the BiPAP as much as required. So for example, the doctor has suggested that the BiPAP should be put on for at least 8 hours or 10 hours or 12 hours, but the patient won't put it for that much time, because of being in the setting where the patient's tantrums are being listened to. Because in the ICU there is continuous monitoring, so they'll put it because कोई सुनेगा ही नहीं उनको वहां पे. बट इन द वार्ड्स वहां पे बहुत सारी बातें वो ऐसी कह रहे हैं जो स्टाफ में नॉट बी इतना ज्यादा एंगेज है दूसरे कामों में कि वो ध्यान नहीं दे पा रहा है, तो वो इतने टाइम तक लगाएगा ही नहीं. एंड उसकी वजह से नाउ पेशेंट का क्या है, CO2 बिल्डअप हो रहा है, उसका एबीजी डिटीरियोरेट हो रहा है, एंड फिर वो पेशेंट को 1 या 2 दिन के बाद वापस आना पड़ता है इनटू द ICU सेटिंग. सो दिस बेसिकली सीज कि हम एक पेशेंट जो ICU से डिस्चार्ज हो रहा है, वेदर और नॉट ही इज रिटर्निंग टू द ICU. नाउ इट कैन बी द सेम ICU or a different ICU, those can be seen, but if the patient after getting discharged from the ICU should not return to the ICU within 48 hours of his discharge from the ICU. Now this basically tells you about how well the patient was monitored clinically when the patient was in the ICU, because if the patient was completely hemodynamically stable and the patient's needs were completely addressed to, in that case, if the patient is getting a discharge, he will never come back to the ICU. So this is what this KPI captures. The third is the most important one, and it has been stated as mandatory by the NABH. So this is the compliance to R1 sepsis bundle. So many of the audience that is sitting here would know that in the ICU, many patients with sepsis are, when they are assessed, so during their first hour, the first hour of them getting admitted into, either if they have come to the emergency area or into the ICU with sepsis, the first hour the patient should have received fluids. The patient should have been done with the lactate levels. The patient should have been put on vasopressors if it is required. If the lactate levels are more than 4, then the patient has to undergo to be put on broad spectrum antibiotics. So all this has to be done during the very first hour of the patient, if it is getting admitted into if he is getting admitted into the ICU or emergency room with sepsis. So this has to be done. Now, how to capture it is the important part. For example, if you receive a patient with sepsis and the doctors have told that all this needs to be done, the lactate levels have to be measured, and the patient is to be put on broad spectrum antibiotics, and the patient has to be put on vasopressors or crystalloid IV therapy. In all those cases, we again will have to take another sheet that basically is a sepsis care bundle, and will have to be put in the patient's file, that when the patient was received in the hospital, in the respective ICU area, they have been diagnosed as having sepsis, and all these actions were taken during the very first hour of attending the patient. So this is to be done, because many a times we lose out on a lot of patients because of this sepsis. By the time the lactate levels are getting measured, or the patient is put on vasopressors and everything else, the patients, we can lose out on the patient. So the formula for calculating is this: the number of sepsis patients that are receiving the full bundle during the first hour, and divided by the total number of patients that come to your total number of patients that come with sepsis in the respective unit. So this has to be captured monthly. It will be in the unit of a percentage, and this it can be integrated into HIS. So any key performance indicators that we'll be seeing to today, anything can be integrated into the HIS system. But a lot of times, many hospitals will have challenges putting it or integrating it with the HIS systems, because the hospitals are not so technology enabled as of now also, that HIS can have all those things. But there are alternative methods to capture them. The alternative method, as I suggested, can be, you can have a different sepsis care form that you can put on the patient's file. You can also have a separate register for the sepsis patients. For example, you can note down the entries, and you can see whether the sepsis care bundle was adhered to or not. Next, we'll look into the infection control indicators. Now, this is simple because a lot of hospitals are already doing it. We are already checking for the incidence of ventilator-associated pneumonias. So what we do is, the formula is a little tricky. It will be difficult for you to understand as to how to calculate the number of ventilator days, or what are the patient days, for example. So ventilator days, every day of the month, how many patients the ICU has, and how many patients are on ventilator is calculated for an entire month, and that becomes the number of ventilator days. So in the entire hospital, when you'll be presenting it to the assessors from NABH or JCI, so they will have to look at the entire data from all the entire hospital. So any ICU for that matter will have their own set of data, own set of ventilator data. So what the quality cell does is, the responsibility of the quality cells is to collate all this data from the different ICUs. So every ICU will be calculating for every day of the month as to how many patients they have and how many patients are on ventilators. So this will become the number of ventilator days in the month. So that is the number of ventilator days. So how many VAP cases have occurred, in the incidence of VAP cases in that month. So you'll capture that these many patients have had incidences of ventilator associated pneumonia, divided by the total number of ventilator days that you have calculated for your respective ICU. So that is how we calculate the ventilator associated pneumonia rate. This can also be put into the HIS systems, but earlier, as per the 5th edition, many hospitals, what they did was, they had a separate register in their ICUs that basically had the ventilator associated pneumonia, the CLABSI rates, the COTI rates, all the infection control rates were maintained in a separate register. So in that separate register, they only had to put in the patient's name, their CR numbers or UHIDs, whatever the case may be in different hospitals. So that is the identification or the basic demographics of the patient have to be put on, and then whether the patient had ventilator associated pneumonia, so whether the diagnosis was done by which doctor. So we basically put it in a register. So this register basically becomes a evidence of how many ventilator associated pneumonias are happening within the month. So anyone, for example, the quality nurses or the people from the quality cell, whenever they come to you and they want to see the data for last 3 months or 6 months, probably you will show them that register. So that can also be done. Otherwise, for patients, we can also use the ventilator associated pneumonia care bundles. We have different care bundles. We don't have the provision to discuss everything here, but there are ventilator associated pneumonia care bundles. Then we also have the CLAPSI bundles. Now CLAPSI is also similar to that. The number of CLAPSI that have occurred in your respective ICU divided by the total number of CLAPSI days or the central line days, how many patients were on central lines in every day of the month. So this is how you calculate that. Next is the COTI rate, which is also similar to that. Then we have the hospital associated pressure ulcer incidence. Now for the pressure ulcer incidence, the formula is a little changed here. The formula here is that how many total inpatient days. So total inpatient days is, for example, in a specific day of the month, for example, the 1st of August will have how many patients on the beds. We will not calculate the patients who are getting discharged on that day. Now how we do it is, because when the nurses are writing the reports every shift wise, whenever they're closing the reports, they'll put in the census there. So at the end of the day, there will be a census. The nursing supervisors will take rounds and they'll capture those census for every day of the month. This census gets collated for the entire hospital, and that becomes your total number of inpatient days. So this is how you calculate the total number of inpatient days and how many patients who have a new incidence of pressure ulcer. Or for example, a patient may also come to you, because ours is a referral center, so many a times the patients will come from different hospitals or healthcare settings. In that case, our patients may already have an incidence of pressure ulcer. So when the patient was getting admitted, he may already have a stage 1 or stage 2 of pressure ulcer. But after coming to our facility, if there is a worsening of the pressure ulcer, that will also need to be captured. So this is a little tricky, because a lot of times, because nurses, what they think is that it is the onus of the nurses to prevent the pressure ulcers, the incidence of pressure ulcers, and also it is on them to improve the status or the grading of the pressure ulcers. So many a times there will be a lot of reluctance from the clinical nurses to report the number of pressure ulcers, because it obviously puts a question mark on the type of nursing care that we are able to provide. Although it can be attributed to different things, for example, less number of staff per patient that have been provided by the hospitals. There's no time for the nurses because there's a lot of paperwork and everything else. But it basically boils down to how the nursing care is if there is a worsening of the pressure ulcer or there's a new incidence of a pressure ulcer. So what we do is we capture every other pressure ulcer that is developing on the patient that were already admitted but had no pressure ulcer at the time of admission. But also we'll have a look at if the patient was getting admitted into the ICU or any hospital area for that matter, if they had a kind of pressure ulcer that shouldn't worsen over time while they stay in the hospital. So these were the 4 KPIs or the key performance indicators that we captured for the infection control practices. Now we move on to the process efficiency ones. Now for the process efficiency, the first and foremost is the nurse patient ratio. Obviously there will be a lot of questions and it is a little what you can say, a little controversial as to why the hospitals are not capturing the nurse patient ratios or how they are fabricating the nurse patient ratios. But it is a mandatory KPI as per NABH. As per the 5th edition, many hospitals, when they were going for NABH assessments, they basically omitted this particular KPI because they didn't want to calculate it, because it basically creates a pressure on the management to put in more nurses, and that basically is draining out all the money from private or corporate houses. But for government institutions, this is mandatory to be done, that the nurse patient ratio is to be calculated. It is to be calculated separately for separate shifts. For example, in the morning shift, there will be a higher or a better nurse patient ratio as compared to the night shifts. So this is calculated separately for all the shifts. So how do we calculate it? The formula is the number of nursing staff on duty divided by the number of occupied beds. So this also has to be captured every month, and every month, every day of the month, this has to be done, that how many staff are on duty. You can use the staff duty roster for that matter. And then the number of occupied beds also can be calculated using the nurses report books. So this can be easily done. This can be easily captured from the nurses report books, that how many staff was on duty during that particular shift. This has to be done continuously every day of the month. And then it is mandatory that it is to be noted also that the nursing supervisors or the nursing in charges are not included in the nurse patient ratios. So for example, in our hospital setting, ANS ma'ams, because they are in the supervisory level and they are the ward in charges, so they will not be a part of the nurse patient ratio because they are not directly involved in patient care. So a lot of times, because this is a loophole, and many private and government hospitals, when they go for NABH assessments, what they do is they include the nursing superintendents, they include the assistant nursing superintendents also in this, to improve their or to showcase an improved status of the nurse patient ratios. But the assistant nursing superintendents, because they are in a supervisory level, they cannot be included for nurse patient ratios, and only the clinical nurses, primarily the nursing officers and the senior nursing officers, will become a part of the nurse patient ratios while calculating it. So this can also be done using the HIS, but as I told, because everything cannot be put into HIS and everything is a little difficult to get it integrated into HIS systems, so this can be captured using the nurses report books also. Next is the appropriate shift handover compliance. Now, the handover, as I already mentioned, that handovers should be done. Actually, as you can see here, they mentioned a standardized form, that is the SBAR. Now, SBAR stands for Situation, Background, Assessment, and Recommendation. Now, this basically is a standardized format of how the nurses or the doctors are giving handovers during their shift change. So this basically captures the patient's current situation, how the patient is, if at all the patient has a different change in their vital signs or not. So this basically is the current patient situation. Then comes the background of the patient. The background of the patient basically tells about the background of the patient prior to what you received the patient. For example, if I'm coming in the morning shift, to prior to that, at night the patient had an incidence of fever, or patient had probably a seizure. So all this has to be mentioned in the background. So this is the background, this is the current situation of the patient. Then what actions have to be taken or have been taken should come into the A section or the action section. So for example, if the patient is pending for, let's say, diagnostics, for example, a patient needs to be sent for, let's say, a Doppler study in the evening. So that needs to be mentioned in the action. For example, during your shift, the patient had an incidence of fever, for that matter. In the action, you will put that the patient had an incidence of fever, tablet PCM given, or cold sponging, anything like that has been done. So whatever actions have been taken, the key actions have to be mentioned, because a lot of times the nurses, because there's a lot of staff load, patient load is increased in the clinical areas, and there's limited time for giving handovers. So what we'll do is we'll write CSTs, because many times in the handover books we'll have it written that continue same treatment, whatever was being given, follow as it is. There's nothing special to be done in this patient. But actually what NABH says is that using SBAR tool or using a standardized tool will improve the safety of the patients as an individual. For example, for any patients that is having a CST, for example, there are 20 patients in the ward, and for 10 or 12 of them, you have written in the handover communication that CST has to be followed. So that becomes a little tricky to understand for anybody else who's coming for auditing in your area. So what is to be done is using a standardized tool. It can be done easily. It doesn't require much time. We have already done it many hospitals. So a lot of hospitals have developed different ways also to capture how to capture this. But if you visit any corporate hospitals or big hospitals in the private domain, for example, Medanta or even Max for that matter, they will have electronic medical records, and the nurses will give handovers using those electronic medical records only. There's no handover that is given on a piece of paper or on a register where CST or anything else is written. Every patient is given a bedside handover, and every patient's conditions or their situation or what actions need to be taken or have been taken that are important for patient's clinical conditions, and whatever there are recommendations as per you. So this is our this is our assessment of the patient during our 6-hour or 8-hour or 12-hour shift. So when we have assessed the patient, when we have assessed the patient's background and what actions we have taken, we are also worthy enough to write recommendations for our subsequent change staff members to know that these recommendations have to be followed. For example, I saw that the patient has twice an incidence of, during my 6-hour shift, the patient has complained to me, or there were 2 incidences of the patient developing fever or a high grade temperature. Patient was hyperthermic during my 6-hour shift twice, but the doctor didn't listen to me. So now my recommendation will come in the handover communication, that the nurses that are now taking over on that patient will know that this has to be sent to the doctors, or they need to be told that what action is to be taken. They have to make sure. So this is how we improve the handover compliance for nurses. Now this not only applies to nurses, but this also applies to doctors as well. NABH says that when we are checking for handover compliance, the handover compliance will have to be checked separately for nurses and for doctors. So doctors should also have a handover form, or like for example, if we are using registers, they can also have their registers unit wise, and they'll have to give proper S-bar following handovers while their shift is getting changed. So this is how we do it. So now what we do is, there are total number of appropriate handovers that are given, and then divided by the total number of handover opportunities. Now handover opportunities is basically a multiplication of how many patients were there and how many shift changes were there. So in a 24-hour period, for example, your unit has 20 patients, and there are 3 shifts change between night to morning, morning to evening, and evening again to night. So in a 24-hour shift, there will be 3 shift changes, and there are 20 patients in your ward. So 20 multiplied by 3 becomes your total handover opportunities. So 60 is the total handover opportunities. And how do you calculate the appropriate handovers? Now appropriateness, the institution themselves have to decide what the appropriateness is. For example, if we are using the S-bar checklist for handover, in that, let's say they have 10 points. For example, there are 10 points of the nurses while giving handovers, they will have 10 points. Now 10 points may sound a little too much, so we'll keep it at 5. For example, there are 5 points. The 5 points have to be given handover, and if they were done appropriately or not, somebody or some supervisor will have to be there during the shift change. Now there can be, you can use it as a sample method also. It doesn't need to be rolled out in the entire hospital, or you are checking every unit's handover compliance need not be checked. It can be taken up as a sample from certain places at different times of the month. So when the handover is taking place, a supervisor will be there with the checklist, and they'll see as to how many patients handover was given appropriately. So out of 5, if 4 points were met, you can call it as appropriate. If 3 points were met, you can call it as appropriate. But if less than 3 were met, then you will have to term it as inappropriate. So that can be decided by the administration themselves. So our nursing administration can decide as to how many points will be considered as appropriate during a shift change. For example, we do it as 3 out of 5. So if at all the nurses are giving handovers, a supervisor is sitting there, and then they see for every patient if all these 5 points were discussed, so that will be an appropriate handover. So this is what appropriate handover means, divided by the total handover opportunities that I told is to be calculated by the total number of patients in your area, multiplied by the total number of shifts that are changing within a 24-hour cycle. So that is how you calculate the appropriate shift handover compliance. Now this will, as I already mentioned, will be captured separately for nurses and for doctors. So now we have come to the initial assessment. Now this is an important part here, because the time taken for initial assessment is very important, because the NABH says when the patient is received into the hospital area, so it can be any area for that matter, when the patient is coming to the OPD, they are coming to the emergency areas, or they're getting directly admitted into the wards. Whenever the patients are getting admitted into the wards, how much time is taken for the doctors to complete the assessment? Because the exact care or the actual care of the patient may not begin until the assessment by the doctors is complete. So this is an important KPI to discuss. So this will begin from the time when the patient has arrived at the bed of your ward. So when the patient has come into your unit, when they have received a bed on which now they are put, so the time begins from there, and the time will end as to when the clinician or the concerned doctor has completed the assessment. Now this is important, because many a times what the hospitals will do is, because the time may be, in government hospitals it is there, the time may be a lot longer than what the private hospitals have. But what they do is, to reduce the time, they'll capture the time as to when the doctors have entered into the patient's area. So when the doctor has come to my area for assessment, they'll stop the time there. But it is not so. NABH says that the time should be calculated as to when the assessment is getting completed. So when the doctors have completed the assessment, that time and the time from which the patient was on the bed of the respective clinical area was. So this is the time that needs to be captured for knowing as to how much time was taken for the initial assessment to complete. This can be done separately for ICUs. For ICUs, we keep a benchmark of around 1 hour. The patient needs to be examined by the clinician within 1 hour of the patient getting admitted into the ICU area. For wards, you can have a longer duration. You can keep the benchmark at probably 4 hours or even 6 hours, that the patient, because those are more stable patients, and when they are coming into the wards, doctors may have already examined them in the OPDs, and then they have decided to admit the patient in the ward. So the primary initial assessment might have already taken place. For wards, you can keep the benchmark at 3 hours, 4 hours, or even 6 hours also. But for ICU settings or even the emergency settings, the benchmarking will be very stringent and it will be less than 1 hour. Many hospitals have achieved the time taken for initial assessment in the clinical areas, primarily the ICUs and ERs, to less than 30 minutes also. So whenever a patient has come to the ICU, within 30 minutes, the patient is getting complete assessed. The doctors have completely assessed the patients, and the care has now begun within 30 minutes. So this also is important, following, for example, the golden hour principle in many emergency conditions. For example, if the patient has come into the emergency areas with signs of stroke, so during that 90-minute, there is a golden time period of 90 minutes. Within 90 minutes, the thrombolytic therapy has to start. For sepsis, we already saw, for sepsis, within 1 hour, all the lactate levels have to be checked, and whatever the bundle says has to be complied upon. So in the care areas where emergency care or intensive care is required, we'll have to keep the initial assessment duration very short, probably under 1 hour or under 30 minutes. But in the routine care areas, in the wards, it can be close to 3 or 4, even 6 hours also. So how do we calculate it? We use the sum of time taken for assessment. So this has to be calculated in minutes, and then it is to be divided by the total number of admissions. So how we calculate the time for every patient? This can be done using the HIS. It is simpler to embed into the HIS as compared to putting it on registers, because this cannot come on registers. The nurses will have no time to see. The nurses will obviously note in the admission register or the transfer register the exact time and date of the receiving the patient. They will put in that, but they won't have the time to put in the time as to when the initial assessment by the doctor was completed. So it is difficult to know as to exactly at what time the doctors have completely assessed the patient. So this cannot be put into the registers. This will be better embed into the HIS. So whenever the doctors have completely assessed the patient, they themselves can put it on the HIS that the patient has been assessed or the patient has been attended to. And the HIS can track whether the patient, or at what time the patient was received into that area, and at what time the doctors have punched in the time that the initial assessment has completed. So this can be done with the HIS. So this is how it can be done. So this system basically generates a timestamp at the start time. Also, when the patient has come to your area, the HIS will show the exact time and date the patient has been received into your area, and then subsequently, when the doctors have completed the assessment, they can put on the HIS there itself that the assessment has completed. Now coming to the patient safety and experience indicator. So this basically will be pertaining to the patient safety in a nutshell. The first is the medication error rate. So this also is a little difficult to capture, because the medication errors, for example, the nurses, as we all know, have always been called upon as the backbone of the healthcare facilities. Now the backbone has to take an onus on itself that when the nurses decide to do something, there's nothing that can stop it. For example, if the nurses decide to capture a KPI, there's nothing that can stop it. If at all the management is giving liberty to the nurses to, for example, go for the capturing of this KPI, for example, if the medication error rate, now for example, if you're taking it and we see that the medication error rates have to be captured, if the nurses feel the need, if they think that it is important to capture such an incidence, and if they feel that, as sir suggested, Dr. Shaleen suggested, that the administration has stated that it will be non-punitive, there will be no punishments as such, but it will be in the benefit of the process or in the benefit of the patient safety. If you're doing it, it can be done. So the management, first and foremost, the management has to decide whether all this has to be captured and done, and then the backbone of the hospitals, the backbone of the healthcare facilities, the nurses will have to decide that whatever incidents, because they are the first responder in any patient situation. For example, if you're talking about medication error may be as small as giving, for example, a patient was to be given 100 mg of medication, but because of some confusion we gave 110 mg or even 101 mg. That also basically by definition is considered as a medication error rate. If the drug was supposed to be given at 1 o'clock, and for routine medications, if it is given +1 or -1 hours, not beyond that. For example, if a drug was supposed to be given at 1 o'clock, so if you are giving that drug at 12:30, it can be considered okay. But if you're giving it at 12 p.m. or 12 noon, if it was supposed to be given at 1, so there's a 1 hour window. You are giving the drug 1 hour prior to what the suggested time was. That also comes under medication errors. So all these errors, basically, who will report that? This will be reported by the nurses. Now, in government settings, as I already told, it is very difficult to capture all these KPIs, because obviously, given the staff load, given the amount of work that the nurses have in the short duration of their shift, for example, in a 6-hour shift, the nurses have tremendous work to do. They have to look after the inventory, the stores, they have to look after the reporting and everything. The patients are coming and going out. There are multiple patients going for diagnostics. There are multiple doctors that are coming for rounds. So while all this is happening, you'll have to take out a particular time to give medication to the patient. So every unit or every area of the hospital has a specific criteria that they follow while giving the medication. So while giving medications, this has to be taken care of. So medication errors is a very detailed topic to be discussed. So what we follow is we follow the NCC MERP definition. The NCC MERP is very stringent. It cannot be followed by any hospital. Any hospital that is giving a good medication or a very less medication error rate is basically faking that data. This cannot be done, because what the MERP or the medication error reporting protocol says is, that is the National Consulting Council for Medication Error Reporting. So basically they have what we call that, they have a form which needs to be used for every patient, and there are the number of opportunities will be multiplied by the total number of drugs that are given to the patient. For example, the medication errors can have different rates. For example, there may be a error when the doctor is prescribing the medication, or when the medication prescribed by the doctor is getting translated into the medication chart. For example, the look-alike or sound-alike medications, we all know about that. So for look-alike medications or even sound-alike medications, when the doctor is writing ceftriaxone, for example, but their writing may not be evident so much. So what the nurses have now translated it into their medication chart will be a different form of cephalosporin. For example, a ceftriaxone can be given as a cefotaxime, because the spelling might be the same and the look of the writing, what the doctor has written in the medication sheet, might be different. So this also becomes a medication error. Now next, the medication error then maybe come to the look-alike, sound-alike medications. The vials, for example, a few times back when I was in the clinical areas, I saw that the ondansetron and the tramadol vials were completely similar. This last. So the look-alike medication, so there will be errors in handling the medications also. Then the administration of the medication, it will be difficult for the nurses to give it at the exact time. There might be changes in the frequency, or there might be changes. For example, when you were noting down the patient's medications, you wrote OD as BD, so that type of error also come. So all these comes under the medication errors. So there will be many medication errors that are actually happening, but very less or even a minuscule of these medication errors are getting reported. So it is very stringent for the nursing fraternity to note down this as per the MERP rules, but yes, it needs to be done as NABH says. Next, we have the ADRs. Now we have a proper ADR monitoring cell here. You already know about it. So whenever a patient has incidence of an adverse drug reaction, that needs to be reported properly, so that proper investigation as to whether the problem was with the drug or was with a specific batch of a drug, or whether the manufacturer has to be told about the type of drug that they are fetching out to hospital has to be done. So ADRs also have to be reported. Next is the hand hygiene compliance. For this, we use the WHO observation tool. So this also is done as a sampling. So in the sampling, whenever the nurses are performing hand hygiene, there are 5 different moments of hand hygiene. As per WHO, we all know about it. So before touching the patient, after touching the patient, before performing aseptic procedures, after any touching the patient surrounding, and after aseptic procedures. So all this has to be taken, all this has to be known by every nurse, especially in the ICUs, because there the 5 moments of hand hygiene are strictly complied to. And there we use the WHO observation tool for the steps of hand washing or the steps of hand hygiene, whether they were done properly or not. So this is how we capture it. This can be done as a sampling method. So this is the implementation strategies as to any hospital that is going for quality assurance, or if they are going on the benchmarking for quality and patient safety, they can go through these 4 phases. The first will be the assessment and gap analysis. First, we'll have to look as to where we stand currently, what the standards are, and where we are standing currently. So that is the gap analysis. So we have to conduct a comprehensive audit of what the current practices that are being followed in our hospital. After this gap analysis is done, we have to maintain a unified documentation system. Now, this documentation will be responsible for capturing the KPIs. This will also be responsible for the administration to know as to what is to be done in subsequent times. Then we can go for staff training and culture. Now, staff training is important. This is one such initiative that we have taken here by the help of Join ma'am, and this is commendable that she has come up with an idea that there should be staff trainings, and it should be longitudinal and continuous. So because every other month or so, there are change in standards, there is change in practices. Sometimes I might become complacent. मेरा आज मन नहीं था, तो इसलिए मैंने थोड़ा जल्दी दवाई लगा दी, मुझे आज दोपहर में जल्दी जाना था बिकॉज घर पे कोई काम था. तो इस तरीके से हमारे जो KPIs हैं बहुत फॉल्टर होते हैं. सो एवरी मंथ एंड कंटिन्यूएशन में अगर हम ये कैप्चर कर रहे हैं, एंड देन उसको कैप्चर करने के बाद जो इनसाइट्स हमें मिल रहा है, अगर वो हम नर्सेस को बता रहे हैं थ्रू दीज लॉन्गिट्यूडनल ट्रेनिंग प्रोग्राम्स एंड व्हाट नीड्स टू बी डन एंड हाउ इट इज टू बी इम्प्रूव्ड, तो वो एक बहुत इंपॉर्टेंट पार्ट बन जाता है आपकी क्वालिटी जर्नी का. एंड द लास्ट इज कंटिन्यूअस मॉनिटरिंग, बिकॉज कंटिन्यूएशन में रहेंगे तभी, जैसे मैंने बताया कि क्वालिटी या पेशेंट सेफ्टी कोई डेस्टिनेशन है ही नहीं है, वहां कोई पहुंच ही नहीं सकता है. वहां पहुंचने की सब लोग बस कोशिश कर रहे हैं उसकी होड़ में. एक्सीलेंस का रोड मैप अगर देखें तो हम लॉन्ग टर्म विजन और शॉर्ट टर्म विजन में इसको डिवाइड कर सकते हैं, बट दिस बेसिकली मींस द सेम थिंग कि आप 0 से 3 महीने में अपना गैप एनालिसिस कर लीजिए, देन 3 to 6 months में आप अडियरेंस चेक करिए, एंड देन जो अडियरेंस का लेवल आया है, जो कंप्लायंस का लेवल आया है, सब्सिक्वेंट मंथ्स में उसको इंप्रूव करने की कोशिश करेंगे. सो एक्शंस में ये बहुत इंपॉर्टेंट है कि सबसे पहला हमारा लीडरशिप आता है. लीडरशिप में क्वालिटी एज अ स्ट्रेटेजिक प्रायोरिटी हमारी लीडरशिप को डिसाइड करना ही पड़ेगा. कोई भी हॉस्पिटल का टॉप लेवल मैनेजमेंट हैज टू डिसाइड कि हम क्वालिटी के पाथ पे जाएंगे कि नहीं जाएंगे. सबसे पहला इनिशिएटिव हैज टू बी टेकन अप फ्रॉम देयर. हम लोग कितना भी ग्राउंड लेवल पे क्वालिटी की बात करें, कितना भी हम KPI कैप्चरिंग कर रहे हैं, इंप्रूवमेंट्स कर रहे हैं, हैंड हाइजीन प्रैक्टिसेस में मेडिकेशन एरर रिपोर्टिंग कर रहे हैं, सारे केयर बंडल सब फॉलो कर रहे हैं, बट अनलेस एंड अनटिल द मैनेजमेंट डिसाइड्स कि quality is a good initiative and has to be taken up in the hospital, nothing can be done. The second is monthly review by the management. The management has to be getting actively involved in the continuous monitoring process. So if you are capturing KPIs, and if those KPIs are telling you a story, so KPIs will always tell you a story as to how the trends are changing over a specific time period. So this story needs to be told to the management, and if there are important steps that need to be taken, for example, the nurse patient ratio is getting deteriorated in a hospital, or for example, the patient care is getting affected. In earlier slides we saw that the patient's families or the patient satisfaction levels are not up to the mark. The patients are complaining about the kind of nursing care that they're receiving, they're complaining about the kind of food that they're receiving, they are made to wait for diagnostic services. All this comes for the management to see that because the KPIs or this data is giving you a story, so this story needs to change, and how they change it, that is up to them. So leadership has to decide, and then they have to give a proper resource allocation for quality activities. Then the technology, obviously HIS may be used. Then we have teamwork, which is important because we need to have quality champions in every area of the hospital. Now these quality champions will not only be responsible for taking care of the compliance standards, but they'll also be responsible for knowing as to if the staff is having a problem. Now I cannot impose that a specific area has to report medication errors. If the area is not reporting, there might be some problems that the staff is facing at that level. So this needs to be taken care of, and it can only be governed by having a good teamwork, by having a team of quality champions that are repeatedly taking round in the ground areas, and then they're seeing as to what the problem the staff is facing. So that is to be done. Then there has to be transparent reporting, obviously, because it needs to be transparent. Otherwise, there are a lot of things, a lot of KPIs, as you might already have visualized in your head, that many KPIs may not always be accurate. For example, if a hospital is saying that they have a 10% medication error rate, that basically is a fabricated data, and that cannot be true. So that is why, because we have to have a transparent reporting system. Then we have to have a, as Dr. Shaleen also told, we have to have a non-punitive incident reporting. So we have to see that if a staff is reporting, for example, if we are reporting ADRs, the question doesn't come to me. For example, as you know about the Good Samaritan law, that earlier when there was a roadside accident, people were very reluctant to take that patient to the hospital, because if they take him to the hospital, he'll come under the medical legal and everything. There will be investigative procedures that will be performed on the patient who has on the person who has brought the patient to the hospital. So then the government decided to fetch out the Good Samaritan law. So the Good Samaritan law basically protects the bystander. For example, if I see an accident, I take him to the hospital, I will not come under the medical legal responsibilities, and I'll be free of those responsibilities. So that is why a lot of times now the patients are coming to the hospital with the bystander who doesn't even know the patient. So this is how the management or the administration decides that if at all the nurses or any staff for that matter is reporting incidents, is reporting medication errors or ADRs, there will be no punitive action against that particular individual. It will only be used for the improvement of the process as a whole. So this has to be done. Then recognition may be one of the things which is important. So as we move forward, we can also give recognition to areas that are performing better. So this was all about it. Now summarizing it, already I've done a lot of this. So at last, I would like to say that if you're talking about KPIs, if you're talking about key performance indicators, so whatever, if you want to lose weight, you'll have to measure your weight first. So if you're going for a journey that is about to bring a change, you'll have to measure it first. So if you're saying that patient safety has to improve, if you're saying that medication errors have to reduce, if the incidence of patient falls or pressure ulcers have to reduce, we'll have to measure it first, and for measuring it, we'll have to use the KPIs. So that's all. Thank you so much.